Welcome to the Behavioral Health Brief, presented by Turn Behavioral Health Services. Behavioral health is about people who deserve compassion, dignity, and the opportunity to heal. At Turn, that belief drives our mission of improving lives. This podcast brings together behavioral health expertise and real stories of transformation to elevate the field and inspire meaningful change. Well, welcome to the Behavioral Health Brief today. And today I have my co-host, Dr. Wendy Broughton, who is our Chief Operating Officer at Turn Behavioral Health Services. And she is an individual that supports not only myself, but our entire company on the operations side. She's been my confidant for 10 years that we've been working together, and it's been a true pleasure. Wendy, welcome to the Behavioral Health Brief.
Thank you, Jim. I'm excited to co-host today and to jump into it with our guest.
Yes, Dr. Bergmann, honored to have you here today at the Behavioral Health Brief. And as a behavioral health leader with years of experience in mental health and substance use treatment and crisis care. I think that crisis care, as we've experienced in San Diego, has really moved us forward. He's helped shape innovative and behavioral health programs, both locally and nationally. Dr. Bergmann, welcome to the show.
Thank you so much. It's a pleasure to be here.
Great to have you. And so I'd like to start off with maybe just your personal journey this morning. If you could share with us how you started your career, what led you to get into this industry of behavioral health and substance abuse, and you've run one of the largest systems in the state of California. What inspired you to enter this field?
I have probably a kind of unusual trajectory into behavioral health care, and maybe in particular into work running a massive bureaucracy. I actually am trained as a clinical social worker, but also as a cultural anthropologist. I think I am the only cultural anthropologist to run a county department with 1,500 employees. And I did my doctoral training at the University of Michigan. I did field work, ethnographic field work in the city of Detroit, and actually was funded by NIH. Remember NIH?
Yeah,
NIH used to fund
yes.
research and stuff like that, back in the day. I actually had NIH funding to spend 3 years doing ethnographic field work with young African-American men working in the drug trade in Detroit. Wow. And so just incredible and really harrowing experience. Most of the kids with whom I was working. I was an ethnographer, which meant that I was sort of doing participant observation. I was sort of deep in the game in Detroit. And this was sort of toward the end of the last century and just over the first few years of the century that we're in right now. Most of the young people with whom I was hanging were selling heroin. And my interest was at that point was really driven kind of by an interest in, sort of economic disenfranchisement, by racial inequality, and by how mental illness and substance use disorder are sort of refracted through really complex histories that are national, that are global, but that are also really importantly local. And how those impact people differently depending on their stations in life, their demographics, and the sort of very particular situations that they find themselves in. So my interest initially was in kind of really big questions. As I sort of spent more time with communities of people who were parts of illicit drug markets, but also parts of communities of people really afflicted by the use of substances and by what is so frequent concurrent mental illness. My sort of area of focus shifted from the illicit economy to people with these diagnoses, people needing care. And I moved relatively quickly from being a researcher. I was faculty at Oregon Health and Science University up in Portland. I was at UCSF. I was at the University of Michigan, into a person interested in making the system of care better. And I think, I'm imagining we'll have opportunities over the course of our time today together to talk about what is sort of historically been structurally challenging with behavioral health care, what sort of calls for urgent change, right? These are like the pretty kind of conspicuous things. And it was very hard for me not to be responsive to those things. So I ended up kind of like, I didn't anticipate this when I was studying anthropology, I'll tell you, but I ended up shaping a career that was really about trying to kind of fix in foundational ways the nature of the care system for people with these conditions.
You know, Luke, you remind me of this, the fact that you got into this notion of research and data and what drives populace, and whether it's disparities or generational influence, economics, positioning, that kind of thing, environmental influences of health, right?
Yeah.
Environmental predictors of health, all of that. But what I love about what you just shared is the fact that you tied that to people. So yes, there was this group, and you can refer to them as a group, but you got to know the faces and the stories, I'm sure, and the families of these people, which really, I mean, Jim and I talk about you a lot in terms of like your reputation precedes you in a good way. So be proud of that. But the fact that I think that you know how to see people and then let them be seen, and they feel that way with you. Yeah. There's something very special about that I think you bring to your work that I don't know that everyone at that level, you, like Jim has said, you've been at that director of DBH level. I don't know that everyone has that benefit, but I think that that's really unique to your career.
Oh, I appreciate that. I mean, I will say as a social scientist, the thing that was most compelling for me was to kind of take apart that story that you hear so often, in particular about young black folks in inner city America. Right? I was working in Detroit, which sort of has a reputation that also precedes it, not in a positive way in most cases. And people think about that community of people, young black folks, in a way that is, in fact, very homogenizing, that doesn't really honor or value the distinctness of each of those people, and frankly, the distinctness of even, specific localities, right? The number of people who would come up to me and say, after becoming familiar with my work, I ended up writing a book about it, and book tour and all the stuff. People would say, God, it's just, it's so real. It's like The Wire. Have you seen The Wire? The Wire is so amazing because it's so real, people would say to me. Like people with whom I was interacting, at universities. And I'd say, interesting. How do you have even the foggiest notion about whether or not The Wire is real, right? So people have this sense about what is authentic about the inner city, based in most cases just on sort of mass marketed stereotypes about the inner city. The fact is, The Wire, which takes place in Baltimore, represents a city that's vastly different from Detroit, or the experience of people in Detroit, which is vastly different from the experience of people in San Diego, Los Angeles, San Francisco, et cetera, et cetera. It's so important that we look not just at the distinctness of particular people with whom we're engaged, but that's the distinctness of the contexts that, in which they've sort of grown up and emerged.
Let's go back a bit. A real quick question, but thank you for sharing. I learned something new again about Dr. Bergmann today.
I got stories.
But the cultural anthropology, as a young man, what was your trigger? Who was your mentor that led you into the field from cultural anthropology into behavioral health? Yeah. What was that momentum? Because I can hear it.
Yeah. Oh, yeah. Well, this is gonna be a weird episode. Jim.
I love weird episodes, so let's go.
So that probably the person who was most compelling for me was my dad. And I'm not going to cry like Tom Brady talking about my dad, but I might. So my dad was a philosopher, an existentialist philosopher. He was the child of a Lutheran minister, grew up in the Austrian Alps during World War II. Made it to the United States because he won an essay contest about democracy, and became a philosopher because he wanted to be something like his dad, but very different from his dad. Existentialist philosophy versus, the pastor of a Lutheran church. I also wanted, I think this is true of lots of young men growing up, right? They want to be like their dads and also very different from their dads. So I was very, very inspired by, like his intellect, but probably most inspired by the fact that he was interested in taking rigorous intellectual consideration to making actual, real change in the world. So he was a philosopher, and all of his work was on Hegel and Nietzsche and people like that. But in fact, the stuff he cared most about was very real world stuff. He was famous actually for founding the first teach-ins during the Vietnam War. He was a very, very active anti-war kind of figure during the 60s in the U.S. And then became a labor activist because he studied like theories of labor. I don't want to get too deep into any of that, but he studied theories of labor.
That would be a whole nother session.
That would definitely be another
episode.
So. And did sort of develop this body of work rooted in philosophy during the 1980s recession, when Michigan, he was a professor at Michigan, when Michigan experienced incredible job loss. In the midst of that recession, right, the auto industry in particular. So it was
Lee Iacocca days.
The Lee Iacocca days, that's right. So it's very much about like the marriage of like rigorous intellectual stuff with like we gotta use this. Like we got smart people thinking about stuff. We've got to make that worthwhile. We've got to have impact, to use a word that I know is really important to sort of like Turn's mission. And that's kind of how I felt as an anthropologist. Like, okay, this is like whatever sort of highfalutin stuff, but we have to take it to real world circumstances. And I would say, as somebody with clinical experience, but also as somebody who's an anthropologist, you'd suppose in my work as like behavioral health director that the clinical stuff has been most relevant. And that's actually not true. Yeah. The stuff that's been most important to my work as like a behavioral health director, and before that in New York City, I was assistant VP over behavioral health for the nation's largest public hospital system. The stuff that was most informative of my work was anthropology, because anthropology does this thing, which is that and this is the most basic thing that cultural anthropology sort of asserts, which is question everything, question all of the taken for granted ideas in the world that we inhabit. So don't just sort of assume that somehow it makes sense that we should have a behavioral health system that is structured in this particular way. Don't simply take for granted, and here I'll sort of resonate with your highlight of the word crisis in particular, right?
Yeah.
Don't just take for granted that we should have a system that's oriented around the word crisis. And I have sort of a funny relationship to crisis services in particular, because I am kind of known for building up the, kind of crisis continuum in San Diego. And I also, whenever I get a chance, and I see this as such an opportunity, will say we have got to actually question how it is that we use the word crisis. And maybe we have to turn away from using the word crisis to the extent that we do, because it's really, and I can talk almost endlessly about that, it's very problematic how it is that we take for granted that when we're talking about mental health, we are talking about crisis.
Yeah.
Mental health in the world of healthcare, mental health is the only domain where we use the word crisis, right? There's emergency care, there's critical care, there's intensive care across the physical healthcare spectrum. When we talk about mental health, all of a sudden we're talking about crisis. Now, crisis is a very different kind of idea, right? Crisis is an idea that suggests explicitly this is non-normative. What this person's going through is not normal. That's what crisis means. It means some sort of divergence from what is normal.
Right.
And a lot of what we need to do to sort of help structure behavioral health care so that it makes most sense for the people who most need it, those particular people with those particular experiences, is we need to make it normal. We need to structure it in such a way that it embraces the normalness of behavioral health care, the normalness of episodes of psychosis even. And we have a long ways to go on that front.
That's so
You know,
interesting.
it's interesting. Sorry.
We're gonna talk for each other. This is what we do. Go ahead, finish my sentence, Jim.
No, go ahead.
Yeah.
Okay.
I'll lean to my co-host now.
I'm sorry.
my clinical
I was just
expert.
gonna say it's just interesting because sometimes there's these blanket applications,
Yeah.
and then all of a sudden we get the buzzwords, right?
Yeah.
And so I will say that one of the things that's happening right now, a few of them that we hear is like this notion of trauma, and so there's this over application, this lack of understanding what really is trauma, and not to minimize anybody's experience and how they feel it. That's not the point, but the point is there's this big generalized application. So what happens is then it gets diluted.
Yeah.
The need and the care and the allocation of resources, it gets diluted because there's this just over bearing broad application. And we see it with, when buzzwords start circulating and then it's just, it's an interesting thing when you're talking about that with crisis. It's very similar.
I can remember I was going to bring up one time when I watched you presenting at it might have been Board of Supervisors when they were on the interim because they were remodeling their area.
Yeah.
You were up on Overland and you were bringing your plan out about the crisis kind of stabilization centers. Mm-hmm. We need 5 of them across the county. And I can remember watching that presentation and going, finally somebody's getting it. Finally somebody's bringing something to where we'll have centers for people to go to that can get that care that they need. And I think we were all super excited with that, and we're seeing a lot of it still rolling out today. But that was, and I'm having a better understanding of where you were coming from. But then my question leads me to, with your experience in history, coming into a San Diego, you had to make a transition, because the transition from everything that you had done prior to that and coming in, and now you're in essence running one of the largest behavioral health organizations, close to $500 million worth of budget. What was that transition like for you? And because you almost had to put on your clinical hat one day, then put on a business hat the next, and then a board of supervisor hat, and then some other politicians that probably wanted to understand your theories. But I think that I'd love to hear that transition that you went through.
Yeah, no, it's a great question. Thank you for asking that. I mean, I was working in New York City before coming to San Diego, and I remember talking to my colleagues in New York about so I'm taking this job in San Diego, and I think they all thought, well, San Diego, right? Like you'd be able to do that job with half your brain tied behind your head, kind of a thing. And boy, was that not true. In New York City, and I was working there predominantly during the de Blasio administration. So I was, working as part of the de Blasio administration for Bill de Blasio, a single unitary executive authority. California county land does not have such a simple unitary executive authority, structure. There are 5 members of a board of supervisors. As a behavioral health director, you have to be responsive to all 5 of them. San Diego represents, it's a really interesting time politically in San Diego. Traditionally, San Diego has been sort of a bastion of conservative politics. The board of supervisors have been primarily conservative Republicans for years and years and years. I came in, and actually that's how it was when I first came here. And that was a switch to come from, New York City at the time was like a progressive political pissing contest, right? It was who can be most, wildly progressive, and, and now, right, they're embracing language like socialism even there. I came here, total Republican board, and I had to think, okay, I feel like a progressive. I know I look like a progressive. I used to run a whole bunch of harm reduction programs in New York. This is going to be a problem. So what I did sort of initially is I trotted out this idea of the triple aim. And I remember talking about that a lot in the sort of early presentations. And the triple aim is an idea developed by the Institute for Healthcare Improvement that's really like a core framing idea in how modern American healthcare works. And it puts forward this idea that if you take care of people addressing their particular experiences in care, if you take care of a population of people, so you're taking care of the individual, you're taking care of the population. If you do those 2 things, guess what? Per capita, you are going to save money. because you're going to, if you take care of people, you're going to protect them from episodes of crisis that are very expensive. And so this is a way that, American healthcare, which is managed healthcare, can think about the work that it does so that there's an alignment of saving money, being conservative with money, with also achieving better outcomes. And I have to say, it's an elegant idea. It's an idea I believe in, I would say very, very strongly. It's an ethical idea also. And in fact, I've taken to talking about it in that way, thinking of my dad died 2 years ago now, but
sorry to hear that.
Yeah, sorry to
I
hear
appreciate that. But that's actually, the way I talk now about, about the triple aim and that kind of framework in the context of behavioral health. I usually start by saying, if you work in this field, you do mission-driven work. And if what we want to do with behavioral health care is make it more seamless with healthcare generally, which we should talk more about perhaps. That's a thing that I think it makes sense for us to be thinking about. If you want to make behavioral health care more seamless with the rest of healthcare, not like, characterized by disparities, not characterized by disconnection, not characterized by, like, frankly, lack of, resources generally. If you want to bring those things together, you probably are worried about what it will do to the, to how you are mission driven. You are probably worried about the ethical foundations of the work, right? When the CEO of United Healthcare gets shot on the streets of Manhattan, 3/4 of the country is clapping. That's what America thinks about managed healthcare. Because all they're used to hearing about is denial of access, of curtailment of care, right? Why? So the insurance companies can save money on people. Often insurance companies aren't, to the extent that they should be, driven by that triple aim, right? Take care of the person, be upstream, protect them from an episode of crisis, protect them from having to go to an emergency department, and you're going to do fine with the money, right? They don't always operate that way.
I don't think they think that way. I really don't.
I think it's fair.
I think that's too high for them. That might be, maybe high is not the right word, and I don't want to be
conceptual.
It's
conceptual.
It's outside the realm of their thinking that can actually work. But I agree with you. The day that individual was shot in New York, I think it was. And then the uproar about the individual being arrested for being, in a vigilante type environment. That's right.
He's certainly
that was very eye-opening.
Yeah.
But here's the thing with that though is, on the general public, looking at the general public, what does it say about the general public? They're tired. They're sick of having to jump through hoops for essential care. They don't understand it. It seems like it's a setup, like it's always about the dollar at the end of the day. And you get those, and unfortunately what hits the media is the extreme cases. But we hear about these stories which seem just so common sense. Give them the care that they need. So you can we don't, of course, no one condones anything like that. But when you look at something like that happens, people identify with what drove the person, right? They understand that level of frustration. No one condones it. But again, you got to look at that. There's some responsibility in the system to reflect this, understanding and common sense and care.
I think you hit a very valid point right there about the frustration level of getting the care. I don't know about you, but I dread the day I got to pick up the phone and call the doctor because I know I'm not going to get to see him for 3 months, right? Because they're too busy. So
let's take this kind of, I think we all agree that there is baseline severe frustration with the nature of healthcare generally in this country, right? And I think part of the reason that, that this person, Luigi, I can't remember his last name, has become a bit of a folk hero is that people, by and large, have experienced that frustration with healthcare. I have experienced it. I was behavioral health director in the county of San Diego. My son at the time was 16 years old. He needed mental health care. And I couldn't get him access to health care. through my employer-driven
Yeah.
health plan. It was just wild.
We
right?
get calls like that all the time, or people who reach out when I'm out in public. Hey, my son was great, straight A's, baseball all-star and everything like that.
Yeah.
Now he's kind of fallen off the track. Can you help?
Yeah.
Right? I can navigate him. But it takes so long to get into the system.
Yeah.
Like you said, your 16-year-old son needed health care. You couldn't get him into the system you were leading.
Couldn't get it. And I was leading. I mean, and I've got other stories about needs that my family has had while I was director in San Diego, and couldn't get them help either. I mean, the system is built in such a way that it's extremely frustrating, and people become discouraged, and then they cease seeking care when they need it, which is really problem. So that's baseline. Now let's look at California and behavioral health in specific, right?
I was just getting ready to ask, from your perspective, what are some of the biggest healthcare challenges that we're facing as communities today? Because
very elegantly woven in.
We have so many communities. I think one of the things in the job that I have as CEO of a behavioral health services company is getting out into the communities and seeing the diversity that we have in our state, from the Central Valley, from the rural to the suburban to the urban, and the communities in between that. It's tremendous, the diversity. And trying to understand how we take care of all that diversity that all needs care. Very interesting. So go ahead.
Well, okay. So let me ventilate about this a little bit, right? So this will be maybe a little bit technical, but I'll try to sound
That's why I have
angry
my
enough.
Okay, don't worry about it. We'll follow.
We'll unpack it a little bit. And everybody, I hope your audience stays awake through this, because this is important.
That's good stuff.
So the triple aim idea, right? That like people will cost less if we protect them from costing a lot by protecting them from episodes of crisis, right? That relies on this idea of an incentive, right? That insurance companies, as the payers for all of healthcare, that they face risk, right? Risk is woven into how it is that they function financially. They are paid through what's called capitation. That means they're paid an amount of money per person who is enrolled in that health plan. They're paid that amount of money irrespective of how well that person is doing in terms of their health or their morbidity. So the healthier they are, the better off the insurance company does, right? Because they're paid that amount per person either way. This is in the public insurance space. So they're highly incentivized to keep people well. That's the idea. If they're highly incentivized financially, you can you don't need to talk about the ethical dimensions or heaven forfend, the moral dimensions of how it is that they might operate as their businesses. The fact is that at a basic economic level, they're incentivized to help people stay well. That's the idea. California has structured, in the space of public insurance, Medi-Cal primarily, California has structured care so that managed care plans, in fact, are disincentivized from taking care of people when they are well. They are disincentivized from getting resources to people farther upstream so that they don't go into episodes of crisis. And why is that? That's because managed care plans in the public insurance system in California are only responsible for the behavioral health care of people who are designated as needing mild or moderate intervention. When people are designated with a serious mental illness on the mental health side, substance use is different, weirdly, in California. Anybody, and substance use disorder is a spectrum disorder at this point, anybody with a substance use disorder is the responsibility of the county. On the mental health side, though, and often the co-occurrence of substance use disorder and mental health, of course, have this kind of compounding impact, right? On the mental health side, if you are sort of deemed seriously mentally ill, if you go into an episode of crisis, in fact, you may be a member of a managed care plan, and you may have been tracked by that managed care plan. And that managed care plan may have decided not to invest resources upstream to keep you well. And they should suffer that decision. Right? They should suffer that decision because they are incentivized generally to be paying to keep people. In California, that incentive doesn't exist because county behavioral health departments are deemed the crisis payers. So when a person who would otherwise be a risk for a managed care plan, when they start not doing well, they just get pitched over to the county. I would call that a perverse incentive. In fact, managed care plans are incentivized not to spend money on behavioral health conditions because they face no risk when a person doesn't do well. Person doesn't do well, they go into an episode of inpatient psychiatric care because they've been in crisis. They may have been fine before that, right? But they haven't been getting the ongoing sort of normative kind of chronic illness-oriented care that they need for their behavioral health, for their mental health and wellness. They haven't been getting that generally because the managed care plans aren't incentivized to provide it. They go into an episode of crisis and the managed care plans suffer nothing for it. That is a structural fact of how things happen in behavioral health care in California. And until that gets fixed, it's going to be a big challenge.
You know, it was interesting you mentioned that because the disincentive piece, I was just on the San Diego Health Committee Zoom call yesterday. We had our annual monthly meeting. And a gentleman from the California Hospital Association was on there who was reporting out how their disincentive for making money, that if they make too much money, if their costs exceed a certain level, then they're going to be put on a PIP. And if they don't match that PIP and the outcome isn't good on that PIP, they're going to be fined substantial penalties for that. So why would they take on a severely mentally ill individual that is going to cost them some money to take care of inside the system if they're trying to keep their costs down? So when you mentioned that disincentive, that's how it came up for me. I could hear it yesterday in the meeting. And the hospitals, all of them are on a PIP. You know? So it's just incredible.
And this is like, you know, this isn't sort of a circumstance where we've got a workforce in primary care that doesn't care about people's behavioral health conditions. We do. Primary care physicians, both, like internal medicine people who are taking care of adults, pediatric generalists, they care deeply about the mental health and wellness of their patients. They do care about the whole person, but they sure are not incentivized to devote resources to caring for the mental health of people. We've got 15-minute primary care visits as like a, kind of normative expectation here. How are you supposed to address in the midst of, like in the case of an adult, talking about hypertension, talking about other sort of chronic somatic illness, talking about sort of whatever it is that's going on for a person's health? How in a 15-minute visit are you supposed to meaningfully address anything as complex as mental health? Also, it's impossible, and it's a structural problem.
You're talking about, too, this whole normalizing, right? We've just been having this conversation of what gets normalized. So, people going into crisis doesn't have to happen, but it's normalized. So you think about that individual, you think about their family unit, and then this becomes their normalized dynamic in their family. And we all know this. When there's mental illness, there's substance use disorder, there's anything that's going on, the family is impacted. This isn't insular. It's not just one person and we send them off for care and they come home. Everyone is affected by this. And so you wonder why, we wonder why there's big pharma, right? So there's this, and I don't want to, bag on them totally, but it is this generalized application of it's going to throw medication at something. Prescribe the medication because that's all the time there is and that's what is normal right now. Rather than, as an example, Jim is, one of the things I love when Jim took over is he's very into his health, taking care of himself. And
look at him.
And I know, look at it, it's disgusting.
Pisses me off.
No. The normal person, you ask, like, how was your weekend? And they're like, it was great. I caught a movie with my wife and it was, it was all good, barbecued a little. Jim comes in, he's like, I pulled off 855 push-ups and I rode 70 miles.
Whatever, Jim.
But, so back to...
I'm addicted to health.
Sorry, we're back on Jim. So
that's okay.
The whole point of that is, though, if you look at preventative care, if you look at the way you support your body, you support your mind, the way that you do self-care and take care of yourself, you absolutely can affect how things manifest in your life, whether it's stress, burnout, mental illness, etc. Most people have some resources at their hands. But because we just don't take the time, or there's not the alliance with that self-care, that how is your environment, what are you doing, it's quick and it's in and out. It's like you were just saying, there's 15 minutes in, here's your prescription, how you doing, how's the meds, oh, they're not working, let's prescribe this med, try this instead. There's a place for medication, so I'm not saying that there's not, but what I am saying is there's a plethora of other things that we can be doing in the spirit of preventative care and preventative medicine.
I mean, and it's, I think, become not uncommon knowledge that people with behavioral health conditions are 5 times more likely than those without to visit an emergency department. 5 times more likely
They
than
have a
those
shorter
without to have an
lifespan.
inpatient stay. That's right. We know that alcohol use in particular is a terrible exacerbant to cancer treatment, for example, right? But we don't think about these things in the same space clinically, right? And we've built structures that keep behavioral health care segregated from the rest of healthcare. And we see that. I think it's a little dramatic in California, the way that we've got all these perverse incentives set up. I do think those of us sort of, active in the policy space are interested in kind of what the direction things may go in with a new administration. There's perennial talk in California about shifting to what would be a carve-in. Right now we've got a carve-out where behavioral health dollars are carved out of the rest of healthcare. Maybe that would be helpful. I'll mention that when I was working in New York City, I helped write what's called an 1115 waiver, which is a mechanism from CMS to change Medicaid structure. And so we went from a full carve-out in New York to a full carve-in. I would say 10 years on, the jury's still a little bit out about the long-term impacts because healthcare is real complicated. But boy, did it feel good. Like it felt, and it wasn't just, for people working in hospital settings or other clinical settings that felt good to like be incentivized to think about the whole person. It felt good to people in care. People with whom I was
you can get
interacting.
behind something that makes sense.
Yeah.
You really, you can hear your passion and it makes a lot of sense. And so why wouldn't we want to get some momentum with something like that? Totally. It's very hard when you see this fractured system.
Yeah.
And we were just saying at a former podcast that we were doing that, our clients, people in general, they don't experience their illnesses, their needs, they don't experience them categorically. They don't start and move progressively in terms of what's approved in what system and move on down the line. That's what becomes very frustrating because there's not that common sense behind it. If you could have that common sense, and I love this I was imagining like this lake approach. You have the lake, it's this big resource. I mean, the phrase that's used is a little more modest than a lake. It's a pool, but it should be a lake or a sea or something like that. I'm advocating let's go for a lake swim.
We'll build a data lake, right?
The idea is it's definitely that there should be one fluid pot of resources that, we have latitude as people, kind of caring for the whole person to distribute as we need to. One thing I would say, though, right, that I think is an additional challenge with the current state is that people have learned through interactions with mainstream healthcare to think about their behavioral health as distinct, and usually to think about it with a sense of shame. Right? So where, I think just kind of intuitively people think about themselves as like, a whole kind of cohesive entity. There isn't any institutional thing that has done more to teach people to segregate themselves than mainstream American healthcare. And I would say it is incumbent upon mainstream American healthcare to re-educate the public in care about how important it is to think about their entire person. But that's not going to happen. Just to say, healthcare does what you pay it to do. That's not going to happen until the structure that flows the money, the structure that flows that fluid resource, whether it's a lake or a pool or a sea or an ocean, until that structure changes. I remember one of the sort of signal moments of learning for me when I was working in New York. I was sort of, working in the central behavioral health office for the New York City public hospital system, which is massive, 11 acute care hospitals and FQs and all these things, including places like Bellevue. And I had a problem, which was that I didn't have enough people enrolled in substance use disorder treatment to support the system and, frankly, also to support the money that we needed to draw down from the block grant from New York State. And I was getting all this pressure from New York State. You've got to enroll more people in your substance use disorder treatment programs. And I took a look and I was like, oh, well, we have 4,000 people in substance use treatment in this hospital. Like, that's not so bad. We've got 4,000 people. And then it occurred to me, I wonder how many unique people this massive system is diagnosing with a substance use disorder every year, right? Because the people we have in substance use disorder treatment are people whom we've recruited into substance use care, usually by going to health fairs, by flyering, right? By doing the things that most community-based programs would do. But we're a massive mainstream healthcare system, and no one had ever looked. No one had ever counted in that system. No one had ever bothered to count how many unique patients per year were diagnosed with substance use disorder. So we had 4,000 in specialty care. The data that I uncovered showed that per year, consistently, we were diagnosing 100,000 unique people with substance use disorder.
Really?
Every year.
100,000?
100,000, which meant that we were seeing in specialty care in response to a very serious diagnosis. Right, a diagnosis that, is like going to be foundational to a panoply of additional health concerns. We were managing to get those folks from that moment of diagnosis into specialty care 4% of the time. I showed it to the CMO, who was pissed and excited, and we radically changed everything in that system kind of from that moment forward.
Interesting. Yeah. So I wanted to back up just a minute, because when I heard you speak about the system and as it exists today, I think about advocacy when I think about that. How much is being advocated up in Sacramento right now, or really being talked about at the subcommittee levels of the Assembly and or Senate at California?
Yeah.
Is that really being discussed up there, or is it still not being discussed?
Man, that's a really great question. This is another case where California presents particular challenges, like actually around change, that people think of California as always, miles ahead of the rest of the country with respect to innovative ideas. California, though, in the behavioral health space is saddled with a state authority. That's the Department of Healthcare Services.
DHCS.
DHCS. I will not say anything negative about DHCS, or will I? DHCS is not, let's just say, it's not the most nimble organization.
Yes, it is not.
Right?
It is not.
It's like a bit rigid or crusty, you could even say. It's not strong. That's like the most important thing to note about DHCS, is that relative to the legislature, DHCS is not a strong state authority. It doesn't have what we would call bulletin authority to actually make very many significant changes. Significant change in California has to go through the legislature. It has to, because the legislature decided that it needs to. What does that mean? That means that every single little thing regulatorily that we need to have happen in order for improvements across the system to become realized has to go through a legislative process that is subject to lobbying. So now let's look at the industry. Which aspects of the industry have the strongest lobbying presence? The ones that would stand to lose if we got rid of perverse incentives, for example, right? Managed care, very powerful kind of lobbying presence. It doesn't want things to change. Most recent legislation in California, Behavioral Health Services Act through Prop 1, for example, notes that managed care plans need to be held more accountable, but doesn't actually put in place mechanisms to hold them to account, right? So this is going to be an ongoing challenge. There is right now, and it's getting some. I think people are paying attention to this. There is right now a commission that was put together by the California Healthcare Foundation, a wonderful organization that I do think the state is blessed to have, a body called the Future of Medi-Cal Commission. It is, kind of in the process of convening, and it includes a lot of real smart folks from a kind of a wide array of pieces and parts of the behavioral health landscape. So including people with lived experience, people on the community side, mainstream healthcare side, policymakers, et cetera, to try to sort of envision what what should things really look like? Because we know there are these structural problems that are going to be the things that will, inhibit access to care. How do we address those deeper structural
those are
problems?
really interesting questions. And I think that brings us to a point this morning where we can take a break right now.
Yeah.
But I think I'd like to talk about when we come back from our break is some of the things as CBOs in San Diego, what can we really do to make the shift from an advocacy standpoint? I'm spending a week in Sacramento or maybe more in the middle of August. I'm going to run in with all of our elected officials up there. What's the message that I should really be carrying to them about the system, right? There's one thing to take a message about our organization. Most of them know our organization, but how can I elevate that conversation in Sacramento about the system and the system of care? And I think one of the other things is there's so many different avenues right now, so many different organizations that are advocating for this and advocating for that and overseeing how our industry is working, that maybe we come back to some of that in our second part of our conversation this morning.
That's
so
great.
With that and our audience, we'll be right back.
Improving lives every day and in every way for Californians. This is the mission of Turn Behavioral Health Services. By focusing on wellness, recovery, and resilience, Turn is helping create lasting change, especially for our military community. If you're active duty, a veteran, reservist, regardless of military status, or part of a military family in San Diego, support is here. Courage to Call is a free, confidential helpline staffed by veterans who understand military life. From 8 a.m. to 8 p.m., you can connect with peer-to-peer specialists who are ready to listen, guide, and help on the very first call. Struggling with mental health, food insecurity, finances, housing? You don't have to face it alone. Call 877-698-7838. That's 877-698-7838. Courage to Call will answer your call. Courage to Call is a program of Turn Behavioral Health Services, improving lives every day in every way.
Well, welcome back. And now we're going to enter our section of the Behavioral Health Brief called The Brief. And Luke, I asked you a question about advocacy.
You did.
And what can we do as CBOs, as CEOs, and really help advocate for some of the things that you talked about this morning? Go ahead.
Yeah. So largely what we've kind of described over the course of our conversation has been this rift in healthcare, right? And in particular in behavioral healthcare, a rift between kind of mild to moderate care and serious mental illness care in the state of California. CBOs are positioned critically to actually be able to traverse that gap. A lot of organizations would have a lot of difficulty traversing that gap. CBOs that, and I would actually say that Turn is kind of ideally sized as a CBO to do this work because it can be better done by, I think, a more nimble organization, one with a substantial footprint, but still one that's able to sort of move nimbly. And it really is about innovative partnership with entities like federally qualified health centers, right? So entities that
The True Cares.
the True Cares of the world, or the Family Health Centers, or the San Ysidros. I don't want to get into the politics of FQs in San Diego, right? Because there is one. But I would say like CBOs that have been devoted more to doing county-paid serious mental illness work have opportunities now. And there is a sort of, there's a thread to some recent federal policy that we may talk about. They have opportunities to develop partnerships with FQs that can, I think, do a lot to bridge this gap in ways that the governing entities, counties, managed care plans, the state, et cetera, are not yet willing to do, right? They are incentivized to perpetuate those gaps. CBOs like Turn can actually bridge that by creating partnerships, by working across payers, right? So working with MCPs that pay for mild, moderate care, right? Like CBOs can work with those payers and at the same time work with county payers and create continua of care that bridge that gap, so that people don't feel that, when they go into crisis, all of a sudden they're having this wildly disjointed experience, right? Of like having one set of providers and one set of contacts, and then all of a sudden a different set of providers and a different like authority making decisions about how much care they get and stuff like that, right? CBOs can actually make a lot of that feel much more seamless to the people who need care. So that's one thing I would say, right, is making it clear to people up in Sacramento that right now we've got a system that's defined by these very problematic silos and divisions. And guess what kind of entity is best situated to help alleviate that? It's the, I would say, medium-sized CBO in the state of California. The other thing that I think CBOs are really well positioned to do, and that I think it's important that more and more folks up in Sacramento understand, is to actually teach county behavioral health payers the business of behavioral health. Counties have been longstanding in the business of behavioral health. And I'll just sort of say, you mentioned that when I came into the job in San Diego, I had $500 million budget. I'll just note when I left, I had $1.5 billion budget in that department. It's a massive amount of money, a massive amount of resources. But we weren't built as a department like a managed care entity. We weren't built as a business. We were built as a local governmental thing that was saddled with all the HR problems and all the, stuff that like local government gets saddled with.
Running a business, right? With all that.
Well, it was sort of like trying to run a business in the context of Parks and Rec, and that, I used to say that actually, like, y'all, we're Parks and Rec here. We got to like wait.
That went over well, right?
It went over just like I wanted it to, which was to be a little bit irritating to people. And so counties right now are in positions where they have to function more like businesses, and they find themselves like woefully under-equipped to do that kind of work. CBOs, again, like Turn, that have business acumen, that are interested in sort of new thinking about how to create value-structured payments, for example. We talk about value-based payments that we're putting in place.
Value-based contracting.
Value-based contracting or performance-based contracting. There's a lot of sort of, terms of art. In most cases where counties are doing that, they ain't really doing it. Or they're doing it in such a way that it's not really sort of like driven by sophisticated ideas about what value is. And I think CBOs can help teach them how to do that. It's important, I think, that folks up in Sacramento realize counties aren't all of a sudden, just because DHCS told them to function in this way, and they're not all of a sudden able to do that. And if they're having to manage if counties are having to manage networks of providers that are just like, can't see, can't hear, right, can't taste, anything to do with value, the counties are never going to learn it.
So it's interesting that you mentioned that, because now in San Diego, they're separating off from HHSA.
They are.
And that's a whole nother episode we could talk about. That was
my idea, Jim. You
want
to talk about it?
But I think I'm not sure they know where they're headed with this, because they don't know what's staying with HHSA, right? Nor do we really know what's going. We got a pretty good idea what's going to the behavioral health, but again, they're separating a business organization, which is now going to become two separate business organizations, which is going to take its own challenge. And so for us as CBOs out there, it's a little hard to navigate when we don't get all the information maybe at the right time. But that's kind of a different discussion we can head in. But I like the idea. I just don't understand how it's fully going to get implemented, but I like the idea. I think and what you say about how we have the ability to cross over right now, because we're the thinkers out there. We're the boots on the ground. We know what it takes to operate.
You've got the business acumen, and you've also you aren't governed in such a way that you have to just work with counties. Right? You actually you have the latitude to work with the payers and the care providers.
We leverage that. I think that's what you're saying is like leverage it. Don't just look at it as a workaround opportunity, but leverage systemic change.
That's right. Yeah.
Exactly. And so we do try to mix, sort of the portfolio, not just by services, but by payers as well, because you really don't have a choice but to be successful that way.
That's right.
And I think it's interesting what Jim had asked you in terms of, advocating. And so when Jim is in front of the people that can make a difference, and we explain, at the funder level, we've prepared white papers and we've done, ROI analysis and explained how this could make sense. What really moves the needle in your estimation? What really makes that difference?
In terms of getting resources to CBOs to help them do that kind of work? Is that what you're asking?
Yep.
Well, in my experience, what moves the needle is a very concrete story, right? Like it's got to be specific. It's got to be human. I think we open the conversation by sort of referencing the importance of sort of the human face of all of this work. So bring that in. But I wouldn't shy away from talking about very concrete, very specific business practices that you want to innovate. Now, the way that California works generally is by supporting little piloty things. And I say that in a way that sounds denigrating, which, I don't mean to be, because frankly, like little piloty things can quickly become big piloty things. And that's also how I would recommend things get framed to actors in Sacramento, right? Like you are in a position to like be innovating value structures in payment by innovating methods to bridge the gap between people in care with mental illness in federally qualified health centers to people in care for mental illness or behavioral health conditions in specialty care organizations, right? You want to create pilot structures to do that, to show the world how it works. And that would be very compelling for political actors.
Very good. That was really great information with regard to that. But now we're at one of my favorite parts of the show, and that's community questions.
Okay, I think I'm in charge of this one, Jim. I'm going to let you pick the first one, hand it over. All right, Luke, you ready?
I'm so ready.
Okay, here we go. This is from Sophia from Chula Vista, and she asks, many people find it difficult to understand how major public budget decisions and funding cuts are made. Can you explain how that process typically works? Any insight?
My goodness, that's a big question,
That
Sophia.
is a
Way to
big
go,
question,
Sophia.
Way to go.
So, where I have most experience in California around that question is at the level of county, local government, right? And it is. I think the thing that I would want listeners to carry away is that it's very complex, and it's not just that. What the public will often see is like maybe a decrease in the total budget, and they'll say, why did the behavioral health director decide to decrease like his or her total budget? And it is very seldom the case that that's what has happened. There's so many different things, considerations, people, politics that end up, determining ultimately how a budget gets put together. In California, behavioral health budgets are made up of a bunch of different sources of revenue. There's a revenue source called realignment. That's sales tax. So sales tax is dependent upon, how much stuff people are buying across the state. So there may be a budget cut that you see at the county level and you think somebody decided to cut the budget to that. It could have, in fact, to do with sales tax revenue at the state level. There's another source of funding called Behavioral Health Services Act money. That's money that is colloquially referred to as the millionaire's tax. It's revenue that the state makes from taxing any individual or entity that makes $1 million or more, 1%, and all of that funding, all of that 1% of everybody or thing that makes $1 million or more goes to mental health care. That source of revenue also at the local level ticks up and ticks down depending upon the economy.
Changed really substantially in the last,
dramatically. And
in
so
the
I
last 2 years.
Also important for Sophia and others who would have that interest to keep in mind that the state just made this enormous policy shift. It was a voter-driven thing, I would say. So it's not a thing that you can, necessarily easily blame state actors for. Though I would just note, it was Proposition 1, voter-driven, 20,000 votes.
Yeah.
Was the difference, between approval and rejection. It was approved by 20,000 votes across the state of California. It means that there are some substantial budget cuts coming right now at the county level, not a decision made at the county level at all. That's a decision made by voters across the state of California.
And then implemented by the state. Go ahead.
Yeah, and I was going to say, I think sometimes we hear people equate budget cuts in certain line or what we would consider line items or populations, and it doesn't correlate with a lack of care or a lack of consideration for that population. And sometimes we hear that correlation, and so we want to just leave Sophia and listeners understanding that there's a lot of care and there's a lot of heart at our county and other folks who have to make those really tough decisions. And by no means does it mean anyone cares less about a certain population if that particular budget had been cut.
Because we hear that a lot. Oh, they don't care about this population, right?
Oh, I may have heard that a bit when I was behavioral health director.
I'm sure.
Can I just harp on this for just 1 second?
Yes, go right ahead.
But with respect to kids in particular, that was an issue that got taken to me often was the budget seems to be going down for our littles, our most vulnerable. Like, on whose heartstring does that not tug, right?
Yep.
Part of the dynamic there is that in county behavioral health, funding has shifted from the sources of revenue I was just describing, this like tax revenue driven, kind of designated allocated funding, to fee for service funding. Now, fee for service funding pays for as much services are provided. And so that's another important thing for listeners to be aware of when you're scrutinizing a budget that only is referencing tax revenue and isn't referencing revenue driven by fees that are part of the Medi-Cal system. You're not actually seeing the devotion of funding that's going to different populations.
Yeah, you hear out there in the public on that, just to add in, they don't put any money towards children. It's all towards adult and older adult. Yeah. But it's actually the revenue stream that is out there, and to be able to feed those services that we need.
That's right. That's
great.
Right.
Okay. Well, let's go to number 2.
Yep, let's jump in. Here we go. Kevin from Sacramento wants to know, how can employers create a workplace culture that supports mental wellness?
Oh, gosh, what a beautiful question. Such
Kevin.
A great question. I mean, it has become kind of facile for people in positions of institutional leadership to talk about the importance of mental health and behavioral health. And there's a lot of sort of virtue signaling, frankly, around that without real investments in change that is consequential. I mean, I would just say things that are really important are establishing an institutional cultural expectation that people actually unplug. And that means you, Jim. Yeah. That means you, Wendy.
Yes.
That means that you genuinely, leadership has to model that. You have got to
100%.
take time away, and you've got to genuinely support. You have amazing people who work for you. They also need to really, really unplug. I would say that's a very basic consideration. There's a lot of talk right now about the kind of mental health ramifications of on-site as opposed to remote, as opposed to hybrid. That conversation is happening simultaneously with conversations about caring more about mental health kind of impacts of work environments. There's a lot of data. I would say leaders of institutions need to be held to account to what those data are saying.
That's really interesting point. We really try to push a wellness plan. In fact, we got a new provider this year on our medical side, and they dedicated almost $100,000 to wellness for the employees.
That's great.
To our discretion to use to help motivate people to take care of themselves first, because they're taking care of so many clients, different levels of stuff that the clients are experiencing. So, well, and just to close out, Luke, I want to thank you for being here today. This has been a very educational session for myself. And before we close, is there anything that you'd like to leave our listeners with today?
I hope that I imagine that your audience is it's folks interested in this topic. I would just say what we want to cultivate among everybody in our communities, people who have behavioral health concerns themselves or family members, and this, by the way, makes up almost all the people in our community.
Yes, it does.
That they should understand that things actually need to change pretty dramatically, and that none of the change that needs to happen will happen without their participation in making it happen. People shouldn't just sort of bemoan the fact that we have a care system that is less responsive than they want it to be, they can play a significant role in making the
their
change
voice
happen.
matters. Their voice counts. They need to speak up and advocate.
Absolutely. Well said. Thank you, Wendy.
And Wendy, as my co-host today, what do you have to add today's session and as we go into closeout?
I mean, just, thank you, Luke. I'm so happy that you were able to be here. You're
guys.
a think tank, and at the same time, you're so approachable, and it's very apparent to us that you have a lot of passion in your heart for this work. You care very deeply, and to have those two things married in one person, it's fantastic. We're lucky to have you here today.
Thank you so much,
Thank
Luke.
you.
Yeah.
Thanks so much.
Thanks.
Appreciate it.
This will close out our episode for today, but what an amazing episode with Dr. Luke Bergmann. Wendy, do you have anything as my co-host to add today with regards to Dr. Bergmann?
I mean, I just think he's amazing, and there's a lot of rich information, and I'm sure our viewers took a lot out of it as well. I mean, he's just an amazing addition to what we have in terms of resources in San Diego. He's amazing.
Yeah, and I'd like to end the show today with a moment about gratitude, and I'm grateful today that we actually had Dr. Luke Bergmann on our show. I think this has been amazing, and it's been really an educational opportunity for myself. I'd like to extend gratitude to the behavioral health professionals, peer support specialists, social workers, community organizations, including our own Turn employees who show up every day and support all of our communities. Wendy, would you like to share your moment of gratitude?
Yeah, I mean, I agree with you. I think there's so much out there. I love that people who just leave it on the table, like Luke, like our staff, like you just mentioned, people that have the passion in their hearts to make a difference. And we know that it doesn't go without sacrifice. I mean, Luke was here squeezing us in between demands and his schedule and time with his family. And, this is the way that we move the needle. This is the way that we make change, which is what we set out to do. So I thank everyone who has it in their heart and the passion and to make a difference. It's just what we're about.
And then to just close out today, to our listeners, thank you for spending time with us today. Please like, share, and subscribe. I'm Jim Callahan alongside Dr. Wendy Broughton. This has been the Behavioral Health Brief.
Thank you.
This has been the Behavioral Health Brief, where insight meets impact.